My name is Alethea DeRogers. I'm an assistant professor in the Department of Psychiatry and Human Behavior at Brown University and the Implementation Science Core. I'd like to welcome all of you to the final seminar of our fall 2022 Implementation Science Seminar Series, which has been a jointly sponsored series between the Department of Psychiatry and Human Behavior in the Alpert Medical School of Brown University, Advance-CTR, and the Brown Alcohol Research Center on HIV. It is my pleasure to introduce to you today our speaker, Dr. Amy Nunn. Dr. Nunn is a professor of behavioral and social sciences at the Brown University School of Public Health. She holds a secondary appointment in the Division of Infectious Diseases at Brown University Medical School. She is also the executive director of the Rhode Island Public Health Institute, or RIPHI. Dr. Nunn conducts applied research and leads public health programs focused on enhancing health equity and reducing racial disparities. In 2022, RIPHI launched Open Door Health, Rhode Island's first LGBTQ clinic. Open Door Health provides primary and sexual health care to Rhode Island's diverse population. Open Door Health recently launched a monkeypox hotline and a monkeypox testing and vaccination program. In 2021, in partnership with over 40 institutions, Dr. Nunn also launched Nourish Rhode Island. Nourish Rhode Island draws on the scientific evidence base from Food on the Move, RIPHI's mobile produce market that serves over 5,000 low-income Rhode Islanders every year. With support from the U.S. Department of Agriculture and the AARP Foundation, Food on the Move offers SNAP incentives that double the value of the dollar when customers buy produce with their SNAP benefits. Finally, Dr. Nunn is also principal investigator of an NIH grant focused on training African Americans and Latinx scholars in community and clinical research related to HIV/AIDS, with a focus on training the next generation of scientific investigators in the Deep South. Dr. Nunn has a hard stop today at 12:45, so we will have a bit of a shorter talk and break around 12:30 to allow some time for questions. So without further ado, I'm turning it over to you, Dr. Nunn.
Thank you so much for the kind introduction. My name is Amy, and I am a professor at Brown, and I also do a lot of public health practice work at the Public Health Institute. We started an LGBTQ center in healthcare center in 2020 as a nonprofit organization under the umbrella of RIPHI. It's called Open Door Health, and as my talk today will be about some of the applied work that we've done in public health practice and integrating STI services with primary care, and also more recently our monkeypox work, as we were called to do monkeypox in the last few months. I'm just going to advance my slides. I don't have any conflict of interest or disclosures to report. I don't have any industry relationships. I want to just talk quickly about why we opened an LGBTQ health center. We are the smallest state in the union, but I believe that small is beautiful. Perhaps somewhat surprisingly, we have one of, among all of the states, we have among the highest rates of people who self-report being members of sexual and gender minorities. But we were one of 13 states in the country without an LGBTQ clinic. Something we'd heard in a lot of our research studies, and when I say our, I mean myself and Dr. Philip Chan, who's our chief medical officer, was that people loved getting HIV care at the Miriam Hospital, but were dismayed that the immunology center, where we were both working, did not offer primary care services. And a lot of our patients told us that they were sad that they felt like they couldn't come out to their primary care providers. So we kind of shopped an idea around town to a bunch of different public health and private sector clinics about whether or not they'd be interested in partnering on opening an LGBTQ health center. And long story short, we didn't find any takers. So we ultimately decided to open our own clinic in March 2020, which was, of course, horrible timing. But it'd been a project that had been in the works for over 5 years, so we decided to open anyway. We had kind of a chaotic opening and chaotic starting point for our history, but it all kind of worked out in the end. And just to give you an overview of sexually transmitted services in Rhode Island, our major STI clinic closed in 2011. Then Dr. Chan opened the STI clinic at the Miriam Hospital in 2012 and started an HIV prevention PrEP program there. But there has not been historically an LGBTQ Health Center. Think Fenway, Whitman Walker, any of the other, clinics around the country. And there was real unmet need for sustainable STI services. So they're open 40 hours a week, but also an LGBTQ primary health care center. We knew from a lot of our own research studies too, and let me just preface this by saying we really try to integrate research with public health practice and CQI and everything that we do. Some of our own studies have found that we lost a lot of our patients to HIV prevention services at the 6-month and 12-month endpoint. We had a big R01 where we looked at this at several different clinics across the country. And we found that there are lots of opportunities. Sorry, I'm not sure what happened with my slides there. I think they may have gotten jumbled, but there were big gaps in HIV prevention services. And we found that a lot of people were not retained in healthcare services and in HIV prevention services, largely because of big structural barriers and social barriers like large co-payments, large deductibles, or in more commonly in the Deep South, high rates of stigma associated with being self-identifying as gay or taking HIV prevention medications. And I'll just remind everyone that we know that with one pill once a day, we can pretty much treat and prevent HIV. So we can take care of people and so that they can have long, normal, healthy lives with one pill once a day. And we can also prevent and arrest HIV transmission among people who are at high risk for HIV with just one pill once a day. We found too that our efforts to engage people in HIV prevention services and get them to say yes to those services have been pretty impactful, but they are most impactful when delivered by culturally competent staff. This is the results of some of our other clinical trials, our 34 pilot interventions to both encourage uptake of services and to retain people in services. We've also found that in big team science studies that look at pharmacy claims data among about 65,000 people, that big barriers exist to keep people in services that are both structural and behavioral, structural in nature, that are generally associated with large co-payments and large deductibles. So we lose a lot of people at the pharmacy point of sale. All of this is preventable with wraparound services, and particularly with services that are tailored to LGBTQ populations. This is just an example in a large pharmacy claims study where we identified exactly where people drop off. They drop off at the pharmacy point of sale, and people who are unable to pay those large deductibles and co-payments have about 3 times the risk of HIV acquisition. So these are things that we know could be addressed with culturally tailored wraparound services. We also know that there have been significant gaps in HIV and STI services in the state of Rhode Island, and that the best way to deliver STI services is to integrate it with primary care. But we haven't done a great job of doing that in public health practice to date. All of this, all of our research really informed, and the reason I mention all of our research is, number one, this is a research talk, but also this informed all of our efforts to begin to provide culturally tailored services across the state, and the need to then evaluate the services that we provide as we implement them to know what we can and should do better. And we've really made a big effort to do that at Open Door Health. Another reason that we really need LGBTQ specific services is that we know that the LGBTQ population experiences extremely high rates of discrimination and stigma, that they often are refused services, or they may not have culturally tailored services that respond to their specific healthcare needs, particularly the high rates of sexually transmitted infection and the need for culturally tailored sexual health services or gender affirming care. And people just need a welcoming environment. If they don't feel that they're welcome, they simply won't go to the doctor. We also wanted to help mitigate a lot of the structural problems I alluded to, like high co-payments, out-of-pocket costs, or limited hours. The services that were available in the state were not available normal business hours. And there are sometimes lots of big barriers, with people getting access to culturally tailored services. We really made an effort to address what we think are the 5 A's of healthcare access: affordability, making our services accessible and available, and are we providing the right services? We also have made every effort to accommodate people's preferences about the way they like to experience the healthcare system in a way that is easily accessible and acceptable. Do people feel good when they walk into our clinic? And so when we opened our clinic, we tried to address all the things we knew were big barriers that we found in our research studies, but also just anecdotally in our clinical practice, by expanding our hours, having very generous wraparound services and safety net services and sliding scale services. We wanted to be on a bus line and also accept walk-ins. So a big barrier is just all the process associated with getting a doctor's appointment. So we have opened our clinic for walk-in visits for STIs, and also have really embraced technology as a way to streamline the patient experience, and also for us to collect data on our implementation science programs. And then lastly, we believe that our staff should reflect the community that we serve. So most of our staff members are members of the LGBTQ community, and a lot of them are members of the Latinx community as well. We had a big launch event in March of 2020 with the governor and our entire congressional delegation, the mayor of Providence. And then 3 weeks later, we had to close because of COVID. It was a momentous event, but we were then tasked with developing a robust set of telemedicine services, which we then did. So we opened and closed our clinic twice. But I'm pleased to let you know that we're thriving now. We have about 4,500 patients. We provide primary care, sexual health services, HIV care, and we have a walk-in STI clinic, so people can walk in Monday to Friday without an appointment in the afternoon. And if they do not have symptoms, can be quickly screened for a lot of different STIs, including HIV, chlamydia, gonorrhea, syphilis, and hepatitis C. We started our clinic with grants, but are now really sustained with a pretty diverse revenue stream, including Ryan White HIV programs, scientific programs from NIMH, and a suite of philanthropic grants, as well as our pharmacy benefit program from 340B. This is what our clinic looks like. Looks like a little storefront on the west side. It's about 3,500 square feet. And it's been designed really to appeal to the people that we serve. It does not look like a clinic on the inside. It's not sterile and boring. We have a Frida Kahlo art display, and our design is meant to be playful and welcoming to the people that we serve. We're also on a bus route and in the heart of the southwest side of Providence. So about 30% of our patients are not members of the LGBTQ community, but are folks from the neighborhood that have come in just because of where we're located. This is what our clinic looks like. I'm giving an implementation science talk, so this little detail is probably important. We collect data, population health data, for all of our patients. So when people come in, they actually kiosk in and do a quick survey that for our STI walk-ins, where we collect information about brief sexual history, as well as the social and structural determinants of health. So what does that mean? We collect information on addiction, vaping, housing, transportation, stigma. It's very brief, but we try to get a snapshot and also some basic demographics. And then what happens is that information then pushes to our electronic medical record, but our nurses also have a look at that data while patients are collecting their own specimens. If the patients don't need to see, if they don't have symptoms for STIs and they don't need to see a provider, they can give their specimens and go. And we try to give them their test results in about 24 hours. Our data collection process has also helped us understand kind of the population level health trends among all the people that we serve. These are the bathrooms, our patient bathrooms, where people collect their own specimens. And then we have our own phlebotomy lab, since we do a lot of lab work for STIs. And this is what our clinic looks like on the inside. We also have done a lot of work with COVID-19. Many of you probably recognize some of our work from what you've heard about on TV. We also had a COVID-19 testing program, a drive-through program. At the beginning of the pandemic, the official policy was to require appointments and also to offer COVID-19 only to your patients, and to require people to come in. Well, we knew that wouldn't work for the community that we were working in, and that a lot of those things presented barriers to many members of the Latino community where our clinic is located. So we developed a different approach and really tried to eliminate a lot of those barriers that can often hinder access to culturally tailored services for the Latinx community. That culminated in some of the highest COVID-19 positivity rates of any of the COVID testing programs. And we actually wrote that up and published it in a CDC journal, because providing culturally tailored services often requires overcoming a lot of those structural barriers that I mentioned. So we had bilingual, bicultural staff. We had a drive-through clinic, and we also worked in partnership with the National Guard to set up our program. I really think they were the unsung heroes of the pandemic and deserve a lot of accolades for all the work that they did at the beginning. Over time, we ended up just offering our COVID-19 services on the sidewalk outside of our clinic, which is how we do our screening now. So if people get tested for COVID, we just wheel a little cart outside. But at the beginning, we all had to wear a lot of PPE as we are providing services. We think design matters in the way that people experience our healthcare system. So we have spent a lot of time and energy on creating safe spaces. Some of our transgender patients told us they didn't feel comfortable even coming in the door because they'd had such negative experiences with the health system. So one of the things that we wanted to do was create a space where people do feel comfortable and affirmed. This starts on the outside and is also on the inside. So outside, we have a mural that we did in partnership with the Avenue concept. This is what it looks like. It's about gender fluidity and features a lot of community leaders from across the state. We also, as I mentioned before, have a Frida Kahlo art exhibit, and that's really meant to be a signal of affirmation to the Latino community in the neighborhood that we serve. Frida Kahlo is also gender non-binary. And art just makes people feel good. It makes them feel more comfortable. There's absolutely no reason for clinics to be sterile and boring. And one of the other things that we've done is to develop culturally tailored marketing programs. So when we first launched, nobody knew about us. So we had a lot of focus groups about the way people would like to experience our communications. These are examples of some of the ads that we did on Grindr, Facebook, and Google, which have been highly effective at getting people in for STI services. When we evaluated all of these with click-throughs and even presentation for clinical services. And what we have found is that these tailored marketing campaigns have been really effective at getting the people at highest risk for STI and HIV acquisition in the door. And we know that from the clicks, but also presentation for services and our analyses of how this has been implemented through those kiosk systems. The most effective way to reach people ended up being through Google search and Google ads, which was not what we thought it would be, but that just doing real-time implementation and analyses of those allowed us to identify what were the places where we're getting the biggest return on investment for communications. And then we redirected our efforts to those platforms. Also, we didn't get a ton of traffic from Grindr, but the retargeting from Grindr has actually been very effective in us reaching the highest risk people on other platforms like Google Ads and Facebook, because you can do what's called retargeting, which is when you know someone has clicked once, they can see an ad again. And that's been really effective for us. Our HIV, our STI rates have been extremely high, and I'll talk about that in a moment. The other thing is we tried to offer some communications that were tailored to a more diverse audience other than men who have sex with men. So including our queer women and transgender populations. So these are what some of those ads look like. I love doing social marketing. It's one of my biggest passions, just hearing how people like to communicate and what they like to hear about has been really helpful for us. The other thing I'm really proud of is that the culmination of all of these things together has really culminated in us having a very, very diverse patient population. That slide is actually a little bit dated. We have about 4,500 patients and about 3,000 primary care patients. They're pretty diverse. About 40% of our patient panel is from the Latinx community. 30% of our patients are heterosexual. 70% of them are sexual and gender minorities. And we've had a whole lot of traction with our walk-in STI visits as well. The other thing that's been really effective for us scaling services is to really empower our nurses to work at the top of their license. What does that mean? That means that we have what's called clinical standing orders for our nurses to deliver STI services as well as STI screening and treatment services. And so our nurses end up providing a whole lot of services that in many other places might be provided by what you call an advanced practice provider. But this has allowed us to serve thousands more people. It's been very cost effective, and it's been actually very well received by our patients as well. One of the things that I think we have diagnosed about 10% of all of the state's new HIV cases. The other thing that's really been interesting is that our walk-in STI visits, actually, a lot of the people that walk in for services are not engaged in primary care, but probably should be. So we've had a really high conversion rate among people who come in for STI services. A lot of them end up becoming our primary care patients. And that's something I'm really proud of, given that so many of them otherwise probably wouldn't be in primary care. The other thing I think I don't have a slide on, but it's probably important to mention, is our STI rates are about 6 times the national average. Why is that? I think that's because our culturally tailored marketing programs have really worked at getting the people at highest risk for STIs through the door. And then once they come in, they usually stay with us because they like the way that we provide care that's affirming, quick, easy, and usually pretty inexpensive. So, how do we do this? I think the short answer is we provide culturally tailored services, our communications, everything I've already alluded to. How do we fund this? We have a pretty diverse revenue stream that includes grants for both research as well as programs, patient billing. So we bill for every patient that we can that walks through the door, but we don't turn anyone away either that can't pay. And then we have a big philanthropic arm as well. And then we have what's called a 340B pharmacy benefit program. The combination of all of those revenue streams has really allowed us to diversify our funding which is great for us because we really like to have revenue streams that support our innovative practices, but also help protect our bottom line. Before I kind of wrap up, I just want to talk quickly about monkeypox. This is a funny, cartoon. Just when we thought things were stabilizing and normalizing, I feel like we've been on kind of an emotional and administrative roller coaster like this with the COVID pandemic and also being in startup. Just when things stabilized, monkeypox came along. And so we had to quickly develop a protocol for our response to monkeypox. It was kind of a COVID-19 redux. We felt that we had a clinical and moral obligation to tackle this. It's worth noting that most of the other clinics around the state opted not to. There are only a handful of clinics that are providing monkeypox services, and that's because probably because everyone is short-staffed and there is no sustainable revenue stream for monkeypox. I think we've spent about $300,000 on it all in, including our staff and communications. We quickly developed a communications campaign. We had a mass vaccination campaign, which we closed the clinic on Victory Day and some of the other holidays. We extended our hours and earmarked time for monkeypox vaccinations. We also started treating people with severe monkeypox. And over time, that was kind of the genesis of our programs. Now we're shifting to a model where we integrate monkeypox into all of our care services so that it is rolled in, and our monkeypox vaccines are offered to everybody who walks through the door for STI services. And that has worked pretty well. I will say that there has not been a commensurate federal response. That is unfortunate because we are absorbing all the costs ourselves. But again, we feel like we have a moral and ethical obligation to do that because it is our population that has been most impacted by monkeypox. Sorry, again, my slides are a little bit, the fonts are a little bit off. It's hard to read, but the bottom line is we have provided more screening, vaccination, treatment services than any clinic in the state. And I think that's just kind of a nod to our values and who we are. We think it's important, and we have vaccinated every single person that wanted to get vaccinated at our clinic. And that's something I'm really proud of. So, what do we make of all this? I think sometimes we need implementation science to test things out, to see what works and collect data as we go. We can also use the results of our studies to refine the way that we provide culturally tailored or culturally congruent services to people in need. There is a role for science in all of this. If we had not been conducting scientific investigation along the way, I think we probably would have gotten a lot of things wrong. So one of the things I think that distinguishes our clinic and our services from some in other places is that we collect data about everything that we do. It's a little bit different than doing studies that are simply randomized trials. We collect data on everything that we do. If something doesn't work and our data tells us it's not working, we don't keep doing it. We stop, we figure out what's going on and use the data that we have or interviews with our patients to help understand what we could be doing better. And even though a lot of LGBTQ folks experience horrible discrimination and a lot of stigma, the problems are not insurmountable. We can and should do better. We think we have a moral obligation to provide culturally tailored services to our most vulnerable populations in the state. And if you just adopt a person-centered approach, you can really help improve healthcare access to people who really need it most. I also think there's a lot to be said for innovative models for delivering STIs, like our express walk-in clinic. That's been a real coup for us, and I think also for the people that we serve. And basically all we did was do what our patients told us to do. They said, we want to be in, one of our patients said in an interview, I want it to be like Jiffy Lube. I want to get my my oil change quickly and be in and out. And so that's the way that we've designed a lot of our services, and our patients have really loved it. And I think, there is not a great mechanism for funding STI services. This is a neglected issue nationwide. And even as our HIV rates have gone down, our STI rates have skyrocketed. That's probably because of dense sexual networks and hookup apps that expedite the way that people meet their partners online. And we think that we can and should do better at providing services that respond to those crises. Just want to thank my team, our team members that make everything that we do possible. And I'll close by just giving you my contact information for anybody who has any questions. And that's all I have.
Thank you so much, Dr. Nunn. That was really wonderful to hear about all of your amazing work, and particularly it strikes me the innovation piece, and how that was so critical for developing the culturally tailored programming. So thanks so much. We can, please, anyone who has any questions, enter them into the chat. I have one that I could get us started with. So I was wondering if you could say a little bit more about what you think are the key factors that helped promote the uptake or adoption and also sustainability of open door health. You mentioned a lot of barriers that you had to sort of target to address for it to be feasible and acceptable to patients, but I'm wondering if you could say a little bit more about what do you think was most important for promoting adoption and sustainability?
When you say adoption, do you mean by patients or by our staff?
Well, that's a good question. So there's definitely multiple levels in your clinic. So I'd love to hear a little bit about each level, because that's what I was also thinking. It can be different depending on whether it's at the agency level, the staff level, or the patient level.
Yeah, we have not. I know that adoption can be challenging with staff, because sometimes you have to create cultural shifts. We had the advantage of being new. So I think we didn't have a lot of issues with our providers taking up the services or providing them in the way that we wanted. I think because we built our clinic on a lot of these premises, and I think being in startup was helpful. It was kind of chaotic sometimes, but just we weren't met with a lot of resistance. We just really systematically try to hire people who will embrace a philosophy of continuing quality improvement and doing things a little bit differently. And then in terms of our patients, I find that if you just listen to what patients want, in whatever way possible, whether it's a survey, CQI, or just chatting with patients, they'll tell you what they want. And so if you provide what they want, they will vote with their feet. And I really feel blessed that we have such a great community advisory board that has helped us do that, more systematically.
That's great. Thank you.
And I think our communications has helped.
So sort of thinking about next steps, if, you mentioned that it's a challenge to integrate HIV and STI prevention and treatment into primary care. And especially if you're working with an LGBTQ population, do you have sort of thoughts or recommendations, let's say, for an agency or a clinic that's already in existence that has primary care to try to sort of implement your model? Would there be some key points that you think you would share as these are the things to do to successfully implement?
Yeah, I think HIV prevention starts with testing, and all HIV services, both prevention and treatment, begin with an HIV test. So if one thing that clinics can do is make a commitment to routinely offer HIV testing to everyone who presents. And then to collect information about it and share it with the staff. So to make it part of performance metrics. So we have done that. Every person that walks through our doors will be offered STI testing and HIV testing because there's a high disease burden among the people that we serve. And then we track information on acceptance rates, and also which of our providers are actually routinely offering the test, and how many, the offer rates and the acceptance rates. And then if you share that with providers, it's a good way to do CQI. And we've gotten to pretty much 100% offer rate. That took us a little while, but I think just having data to share back to providers helps. And then once people are offered an HIV test, if they report behaviors that might place them at high risk or they might be in dense sexual networks, you can offer them PrEP, so the 1 pill once a day for people for whom it might be suitable, or you can also offer HIV treatment to people who test positive. So I think HIV testing can be a window into a whole suite of other services. But you have to ask. You got to start with a test.
Right. And starting from that patient-centeredness, sounds like.
Yes.
Well, we still don't have any questions in the chat. I just have one more that I thought I might ask. In terms of your culturally tailoring process, I think you hinted at a lot of important aspects of that process throughout your talk, but just wondering if you could provide sort of like a summary of what was your approach really, or what would you consider your approach or your method to culturally tailor the services, because you clearly did a lot of different things and it was really successful.
You just have to listen to what patients tell you. It's not like I came up with all these things by myself. I mean, these are things that patients were telling us along the way. I think we came up with some of the ways to deliver them, but really they were informed by what patients told us that they wanted. And that's really kind of the bottom line for the way that we provide care. You know, some of that was formally through focus groups or community forums or qualitative interviews, but a lot of it was anecdotal. Some of it was from our community advisory board. But if patients tell you what you want, what they need, why wouldn't you do it? You know, if you just listen to what community members want, and try to accommodate them within reason, your research will be successful. You'll be a better scholar, and you'll also be a better, public health practitioner. So, I do a lot of mentoring as part of my role in the community engagement core of the CTR. And the first thing I always tell everyone is, what do your patients say? What do the community members say? And a lot of people often say, I don't know. I said, well, have you thought about asking? Ask people what they want, and they will tell you what they want. Sometimes you can't do all of it. Sometimes you can't do half of it. But if you can do some of it, you'll probably be more successful in the work that you're trying to undertake.
Yeah, I think that is really came through really strongly, the importance of engaging with your community stakeholders and really the people who are going to be receiving the services, and how important that is throughout the whole process. We do have one more question, and then I know you probably have to wrap up with your hard stop. The question is, can you speak to the makeup of and how you selected members of the Community Advisory Board? Do you meet regularly, individually, or as a group? And how long do folks serve on the board?
Great question. We meet about once a quarter. At the beginning, we were meeting more often before we were opening, because we wanted to make sure that we were getting as much feedback as possible. Now we meet a little bit less often, but we had a formal application process that we advertised and solicited input, and then we selected a diverse group of people that we thought reflected the community, but also that highlighted expertise that we thought would be valuable to the way that we provide services.
Great. And then just one more here as another point. Could you speak about how Open Door Health has navigated working with younger patients like teens and young adults and families, especially given challenges around confidentiality and insurance, et cetera?
Yeah. So we a couple of things. We see people age 16 and up. We do not have a pediatrician on staff, although we're in the process of hiring a family medicine doc who will be able to see adolescents as well. But I think word of mouth is pretty big. We've also done some tailored social marketing campaigns. I think we probably have a long way to go to reach all the adolescents that might be in need. But another reason that we chose our location is because we're right near 3 high schools, the vocational school, classical high school, and another one. And so that people just walk over. And so I think just being accessible goes a long way. And then we've also worked with Youth Pride to help spread the word and have offered our services to their patients as well.
That's great. Well, thanks so much, Dr. Nunn. We have a lot of great feedback, and I think this has been a really fantastic talk, and we appreciate you giving your time.
Thank you. I appreciate it.
Okay. All right. Okay. Take care, everyone. We'll conclude for now then. Thanks so much.
Thank you.